Hi, everybody. Sorry I can't be there with you in person. I didn't realize when I would be traveling to Houston, Texas, that it would end up being nearly 10 below with wind chill this morning, with almost 3 inches of snow, and every single flight going pretty much anywhere being canceled. So I wanted to at least put a recording out there of the eponyms that we were assigned, so y'all could have an idea of the couple that I had seen. I'm sorry we won't be able to do the interactive aspects of this like Dr. Gilliland had put out, but I was really interested in doing the anatomists that I had been assigned and their associated structures. So I'll go ahead and get right into it. So the first one that I had found or was assigned was Benjamin Alcock. His dates are 1801 to question mark, very mysterious. He was born in Kilkenny, Ireland, and he studied anatomy at the Trinity College in Dublin, graduating in 1821, which I think is pretty remarkable given that he was like 20 years old when he graduated. He worked under Abraham Colles, a leading Irish surgeon. So if we are talking about, this whole presentation day is about eponyms, Colles should be another one that should trip memory cue in people's minds. So there are two specific things with Colles that most people remember. The first one, and that's Colles fracture. So that's the outstretched hand fracture. And he was a known, a very, he was a renowned, Abraham Colles was a renowned surgeon who did a lot of orthopedic work. The other Colles, which people may not remember, is Colles fascia. And that is continuous with Scarpa's fascia in the superficial perineal area. So and Scarpa's fascia, if you remember your abdominal anatomy, it's the membranous fascia that's deep to Camper's fascia. And it is also known as the superficial perineal fascia. So once it goes into the perineum, it basically gets renamed from Scarpa's fascia to Colles fascia. So just a nice little 6 degrees of eponyms with Colles and Alcock. But back to Alcock, he became the first professor of anatomy, physiology, and pathology at Queen's College in Cork. But he left pretty soon after that due to a disagreement about cadaver procurement. This is worth a course in and of itself, talking about how anatomy and medical schools got their cadavers back in the early days. There was an anatomy act of the 1830s that talked about how certain schools had to follow certain rules and follow policies and procedures about procuring cadavers. And what the Queen's College had asked him to do was, all the workhouses in Ireland were places where there was a high amount of death. And they had asked him to essentially lie about his relationship with some of the workers, saying that he's family. So they would release the corpses or the deceased to him, even though he wasn't part of their family, and bring it back to the college. He was very much against that. There was a couple of years of back and forth in terms of his resignment of his post versus him getting fired. Ultimately, he kind of left in disgrace from from the institution of Queen's College. So he sailed to the United States in 1859 and wasn't heard from again, which is why we don't know what his death date was. The anatomical area that bears his name is Alcock's Canal. And so this essentially describes the course of the pudendal nerve. Another piece that I found really kind of chippy was this was part of a contribution to the Cyclopedia of Anatomy and Physiology, which was edited by this individual Robert Todd and published during the middle part of the 19th century. And the reviews weren't great about it. I loved this one, a thorough lack of originality, and the articles all deal with subjects in common dissecting room anatomy. But they did give Alcock a little bit of props, he says, except for perhaps those of Alcock, which includes this description. So kind of remembering back to the courses about the anatomy of the perineum and the pelvis, you have these ischioanal fossae, which are paired wedge-shaped spaces lateral to the anal canal. And so you can kind of see them marked out right here in this image in the lower left-hand side. And the pudendal nerve and the internal pudendal vessels enter the canal after exiting the lesser sciatic foramen en route towards the perineum. And that's kind of laid out right here. And then if you take it from a different view, this is actually from the original manuscript in terms of Alcock's descriptions. It's a little hard to see, but you can see right here, this is what he has as his pudendal canal. And it's really this area right here that is essentially what got his name in the anatomy books, and that got him some renown through some of the publications that he had done. And again, the pudendal nerves and the internal pudendal vessels are they innervate and they vascularize the structures in the perineum, so the muscles, the erectile bodies, etc. And so this is where so Alcock's canal is named for Benjamin Alcock, who initially described them in great detail and got a good bit of publicity for his description of them. The next one, who of all of the ones that I had the absolute best portrait because his hair looks amazing. This is Caspar Bartholin the Younger. His dates were 1655 to 1738. He was a Danish anatomist, and he came from a pretty renowned family in the field of anatomy and medicine. He wasn't the Caspar Bartholin the second, because his father's name was Thomas, but his grandfather was Caspar Bartholin the Elder. He contributed to anatomy based on his work with the cranial nerves. Specifically, he was the first to coin the nervus olfactorius and the nervus vagus, or the vagus nerves and the olfactory nerves. Because this was a pretty renowned anatomical family, he published a treatise, a dissertation on the anatomy of a swan at the age of 13, which I think is pretty remarkable. Although from what I read, there's some discussion that maybe his father Thomas actually wrote his treatise, and there might be a little bit of nepotism and some cheating. He definitely would have to go to the honor court here at UNC if he was caught having his dad write his dissertation for him. But he did, despite the fact that his dad did some of this work for him, he did kind of come up with a lot of very original work on his own. He received professorship at the age of 19 at the University of Copenhagen, and eventually was appointed the personal physician for the King of Denmark until his death. So he had, not only was it kind of in his family and his lineage, but he also had quite a bit of talent as well. He is probably, of all of these that I have today, one of two that should be very familiar. And for him, it is for the Bartholin glands. And so he described these first. He was working a lot on cow anatomy, and this is where he first really identified these glands. And it describes the greater vestibular glands. This first happened in 1677 when he described them. As you can see over here in this upper left-hand picture, this is located in the superficial perineal pouch, and it's posterior-inferior to the bulbs of the vestibules. So you'll see that the vestibules are up here, and the bulb is right here, and then here is the Bartholin gland with an orifice that will lead to the vaginal canal. And its function, and he also described the function of this, is to secrete mucus into the vaginal vestibule during sexual activity. For Chip, because I know that he's going to be part of our group, this is homologous to the bulbourethral or Cowper's glands in males. We learned through our preclinical and through some of the studying for our tests that a simple occlusion of these ducts can lead to a Bartholin cyst, and then you can have severe infection, and that's dubbed a Bartholin's abscess. And so the two treatment mechanisms, I remember seeing some questions about these, is either using a word catheter and putting a catheter in to do assist with the drainage, or marsupialization. And over here in the lower left-hand corner, I show a schematic or a drawing of what that marsupialization process is like. And so you can see here that a vertical incision is made into the cyst. So you kind of reveal the cyst from the overlying tissue. And this allows, by by making this vertical incision, it allows for spontaneous drainage of the cavity. And then once that's drained, the cyst wall is everted and approximated to the end of the vaginal mucosa over here and here. And you can see that being done and kind of put together by sutures right here. And this is kind of the process that they're showing you. This is something, I mean, it's a relatively minor surgery, but this is a very sensitive area. So it does require general anesthetic to achieve good marsupialization. So that would be interesting to talk about, not only kind of what is going on here, but also some of the treatment mechanisms that we use to handle these more severe cases. The next one that I had was Gabriele Faloppius, or Faloppio, and he was also known by his Latinized name Faloppius, which is what we have up here in the in parentheses. His dates are 1523 to 1562. I really like this image. It kind of speaks to the time in my mind. He was an Italian Catholic priest and an anatomist. He grew up poor, and part of his ability to get the level of education that he needed was actually to go into the priesthood. And this image right here is him explaining one of his discoveries to the Cardinal Duke of Ferrara. So he studied medicine at the University of Ferrara. He received professorships after his studies were over at that particular university, also the University of Pisa and the University of Padua. Because, I mean, they call these people Renaissance men for a reason, because they have their hands in everything. He was also the superintendent of the botanical gardens, or the botanical gardens at Padua. And his main interest was the anatomy of the head. So we'll talk a little bit about that with some of the structures named after him. But outside of anatomy, he also contributed to practical medicine. He was the first to use an oral speculum to diagnose and treat diseases of the ear. And I thought this was particularly interesting, is that he performed a clinical trial on the efficacy of condom use in terms of syphilis transmission. So he was the first to describe a condom in writing, and he called it a linen sheath that wraps around the penis, and advocated the use of these sheaths for the prevention of syphilis. And so he reports that he tested condoms in 1,100 men, and none of them had contracted syphilis. Now, obviously, I didn't see the data, and so don't know the verity of all of what he reported. Maybe there was some selection bias going on there, but just it was really interesting to know that the clinical trials, even back in the 16th century, it was really interesting to see him kind of test out an idea that he had. So as his name suggests, it's pretty clear what the main one, and that's the fallopian tube. And so his, this is also the other names for the fallopian tube are the uterine tube or the salpinx. You'll see here about salpingectomies as treatments for final birth control. It's also known as the oviduct. And the homologous organ in the male is the rudimentary appendix testis. And that is a remnant of the Mullerian duct, which is present on the upper pole of the testis, and it's attached to the tunica vaginalis. Because we haven't seen a lot of histology thus far, I thought it'd be great to do a nice cross-section of one of the fallopian tubes. He has two other main ones that we might not hear as much about. And the first one is the inguinal ligament is also called the fallopian ligament. And this is also known as the Puppar's ligament. And so this ligament has two eponyms to it. Puppar's ligament, this was another anatomist, and he was later than Faloppio, but he gets kind of dual billing in this eponym game, because he described it and then gave it relevance in relation to hernial repair and surgery, and he called this ligament the suspender of the abdomen. And again, this runs from the anterior superior iliac crest of the ilium to the pubic tubercle of the pubic bone. The third one, and one that I hadn't heard of before doing this discovery, is the fallopian canal, which is also called the facial canal, which you can see from one of Dr. Koenig's earlier lectures is noted right here. And again, I had mentioned that some of his main interest was the anatomy of the head. And so the fallopian canal, or the facial canal, runs through the temporal bone from the internal acoustic meatus to the stylomastoid foramen. And so you can see the Netter drawing here. And I wish this was showed up a little bit bigger, but you can see the facial canal right in here, and you can kind of see this indentation. So that can kind of give you an idea of what this canal looks like on this gross anatomy, or this cadaver model that we have over here in the lower left-hand corner. It's approximately 3 centimeters long, and it makes it the longest human osseous canal of a nerve in the body, which I thought was a pretty cool thing. My last one is Hermann Gartner. He lived from 1785 to 1827. Of all of them, he's the one that I could find the least about. He was a Danish surgeon and anatomist, and he studied surgery and anatomy in London, Edinburgh, and Copenhagen. And he became a military surgeon in 1825, but then died soon thereafter. He is the eponym for him is Gartner's duck, and I thought I would use this to talk about Gartner duck cysts. So, kind of going back to the embryology of all of it, I inserted this schematic in the lower left-hand corner, and you can see that that Gartner's ducts arise from the mesonephric ducts in females, and they may persist between the layer of the broad ligament of the uterus and the wall of the vagina. So if this were male development, the mesonephric duct or the Wolffian duct would go on to form the epididymis, the ductus deferens, the ejaculatory duct, and the semical vessels. And so this Gartner's duct cyst can develop from these embryologic remnants, and you can see on this image, this is a nice way of visualizing this. This has kind of dissipated and been reabsorbed after the female had undergone the development, but here is kind of a remaining remnant of that. It is usually present on the anterolateral vaginal wall, and they're often noticed incidentally on ultrasound or MRI. They oftentimes don't have symptoms, you just kind of notice it. They are typically pretty small. They average about 2 centimeters in diameter, but of course they can be larger. And I thought this was a good time to bring in some of the imaging that you might see. And this is a much larger one than the 2 centimeters. But so on a T2 weighted image, if you're doing MRI, it manifests as a hyperintense signal because most of the content within this is fluid. So you can see the bladder here. It lights up pretty bright on the T2 weighted because of the urine in the bladder. And then you can look at the cyst as well, which also shows up as hyperintense. The contents of the cyst, so you can have different contents of the cyst as well. So you could have blood or proteinaceous fluid, and so that would show a high T1 signal and a low T2 signal. So it really all depends on kind of what's inside of that cyst in general. I also thought that this was, so the treatment for this is if there are some symptoms, the kind of the mass effect of those symptoms on either vaginal issues or urinary issues because of its proximity to the bladder, the surgical removal is an option. And this is a pretty large Gartner's cyst. And this kind of shows exposure of the anterior vaginal wall. And this particular surgery, in this particular case, the cystic area was completely excised. And at least from this case report, it was filled with clear non-mucinous fluid. And then the pathology was sent to pathology, and it was confirmed to be the diagnosis of a Gartner's cyst. So that was the extent of my eponyms. Again, I'm sorry I couldn't be there in person. I hope y'all enjoyed seeing some of these pictures and hearing about some of these scientists, and I'll look forward to seeing you in class, hopefully in a day or so. All right.